Cleft lip and/or palate is a congenital malformation that results from a failure of oral structures to fuse at the midline during the first trimester of pregnancy. A cleft can occur with just the lip, just the palate, both the lip and palate, and can be unilateral or bilateral. Approximately 1 in 700 children are born with a cleft. Cleft lip and palate may occur in isolation or as part of another anomaly, such as velocardiofacial syndrome, Kabuki syndrome, and many others. An interdisciplinary approach is taken to repair and treat the child with a cleft. Members of the team include a medical doctor, an oral surgeon, a pediatric neurosurgeon, orthodontist, geneticist, otolaryngologist, a plastic surgeon, ophthalmologist, and a speech-language pathologist. This diagram outlines the typical sequence in which cleft lip and palate is surgically repaired. The lip is typically repaired around 3 months of age, and the palate is typically repaired around 1 year of age. Today we're going to focus on the role of the speech-language pathologist, here on out referred to as the SLP, in helping to treat feeding and resonance disorders in children with cleft lip and/or palate. Children with a cleft may demonstrate difficulty feeding and swallowing, hypernasal resonance, velopharyngeal incompetence, and articulation errors. I want everyone to take a second and swallow. Notice how when you swallow, your nasal cavity is closed off from your oral cavity. Furthermore, your lips are sealed together and you create a suction to move food and drink, or in this case, just saliva, down into your esophagus. What if you aren't able to seal your lips or close off your nasal cavity from your oral cavity? This is exactly the difficulty that children with cleft lip and palate face when feeding. Children with a cleft may be unable to create a suction around the nipple in order to create an adequate suck. Children with a cleft palate are unable to close off their oral cavity from their nasal cavity and cannot produce a suction to facilitate swallowing. The SLP plays a role in using oral feeding facilitation techniques in order for the child to receive adequate nutrition and teaching caregivers how to use the techniques. There are several techniques that can be used. The first technique is positioning. The child is positioned at 60 degrees with head support, arms forward, and their trunk at midline. This helps to assist with transfer of fluid and decreases the likelihood of nasopharyngeal reflux, or in other words, liquid coming back up through the nose. This allows for improved oral motor patterns, airway protection, and efficient feeding. Another technique utilized is assisted feeding. The person feeding the child squeezes the nipple in synchrony with the infant's sucking efforts to help the child compensate for his or her inability to create suction. This technique requires the utilization of specialized feeding equipment. This technique has numerous reports of success in feeding and increased volume of oral intake. Common assistive feeding devices include the Mead-Johnson Cleft Palate Nurser, which is a soft compressible bottle that is easily squeezed, the Haberman feeder, which is a nipple that releases milk from compression and sucking is not required, and the pigeon nipple, which is soft and compressible and can be used with other bottles. The person feeding the child can also provide lip, cheek, and chin support to facilitate sucking movements. The feeder places his or her middle finger under the chin of the child and the index finger between the chin and lower lip to provide stability of the tongue, lips, and cheeks. Thickening the child's liquids is another facilitative technique that is used. The child's liquids are thickened to create a more cohesive bolus that moves more slowly and allows more time for airway closure. The main focus of these techniques is to ensure that the child with a cleft lip or palate is receiving adequate nutrition. Another role the SLP plays on the interdisciplinary team of cleft lip and palate is in the treatment of resonance disorders that the child may experience.
In order to understand resonance disorders, you need to first understand what contributes to normal resonance for speech production. Resonance, as it relates to speech, is the modification of the sound that is generated by the vocal cords as the sound travels through the cavities of the vocal tract. As the sounds from the vocal cords travel up the vocal tract, selective frequencies are enhanced or attenuated based on the shape and size of the vocal cavities. The length, size, and shape of the cavity of air all play a role in determining the resonance for speech production. For example, when sounds created in the vocal cords pass through a short or small cavity, the higher frequencies are enhanced, whereas when the sounds pass through a larger or longer cavity, the lower frequencies are enhanced. In order to distinguish specific phonemes from one another, the appropriate resonant frequency must be created. Depending upon the phoneme, this may or may not require the closure of the velopharyngeal valve. Nasal phonemes are created when the sound from the vocal cords travel up the pharynx and into the nasal cavity via an open velopharyngeal valve. These nasal phonemes require both the nasal and oral resonance to distinguish one nasal phoneme from the others. All other phonemes are created with a closed velopharyngeal valve and therefore rely primarily on oral resonance. However, there is some resonance in the nasal cavity during these productions due to radiance of the sound energy through the soft tissues of the velum. Once the sound has entered the oral cavity, the resonance is determined based on the configuration of the speech articulators. Based on this information, it is evident that any obstruction or dysfunction within the vocal tract will have an impact on speech production and resonance. Resonance disorders are an abnormality of the quality of speech sounds due to inappropriate vibration in one or more of the vocal tract cavities. In individuals with cleft lip or palate, the velopharyngeal valve is unable to obtain a complete closure due to abnormal muscular origination and insertion points. When an individual is born with cleft lip or palate, there is an absence of midline tissue, therefore creating a cleft and forcing the muscles that typically insert in the palate to do so elsewhere. The muscle that is most negatively affected by a cleft is the levator veli palatini, which is the most important muscle for normal velopharyngeal closure. These abnormal muscle insertions typically lead to velopharyngeal insufficiency, which is an abnormality of the structures of the velopharyngeal valve, resulting in inadequate velopharyngeal closure during speech. A velopharyngeal opening during speech yields hypernasality. Hypernasality occurs when there is an abnormal proportion of sound energy in the nasal cavity during the production of voiced oral phonemes. Hypernasality is often characterized by the low volume, muffled, or mumbled speech sound productions. Although hypernasality typically occurs when there is an insufficient closure of the velopharyngeal valve, it can occur even when the velopharyngeal closure is complete via a submucous cleft. The thin velum allows for sound pressure to travel into the nasal cavity and therefore creating hypernasality. Although speech-language pathologists may identify the cause of abnormal speech, interventions for individuals with cleft lip and palate, along with other resonance disorders, almost always involve medical or surgical procedures. Speech therapy services can and should be provided after the surgical intervention for velopharyngeal insufficiency surgery to target the function of the mechanism. Hypernasality, nasal air emission, and weak consonants can only be influenced from speech therapy when the characteristic is mild, the characteristic is inconsistent, the child is stimulable for a reduction or elimination of the characteristic is due to faulty articulation, nasal air emissions with pharyngeal fricatives or nasality due to an associated ing tongue position with an anterior phoneme such as L. The characteristic is associated with oral motor dysfunction or dysarthria. The characteristic occurs primarily when the child is tired. The velopharyngeal opening is slight or inconsistent as developed by video fluoroscopy or nasopharyngoscopy. Speech therapy is recommended. The following strategies and techniques are offered for use with all clients. For hypernasality, nasal oral contrast, tactile feedback, or the yawn technique. For nasal air emissions, auditory feedback, visual feedback. For weak consonants, visual feedback and tactile feedback is beneficial. For compensatory articulation productions, glottal stops as a substitution for plosives can also be beneficial.
During therapy, visual or auditory biofeedback is key. Visual or auditory biofeedback has the potential to substantially facilitate progress. A nasometer is a common tool for providing visual feedback regarding the client's nasal resonance and emissions. The news is that with treatment and surgery from an interdisciplinary team, children with a cleft lip and/or palate, not in conjunction with another anomaly, typically go on to lead normal lives. The SLP plays an important role in feeding during the early parts of the child's life. The SLP then goes on to help treat the child's difficulty with resonance and articulation disorders. For additional information in regard to the SLP's treatment of cleft lip and palate, please refer to these resources or contact your local children's hospital.